That should be recording now. So lovely to meet everybody this morning. So thank you for joining. I think there's a few more just coming through now. So for those of you who I've not yet met, my name is Sarah Byrne. I'm a Knowledge Mobilisation Fellow here at the ARC, and I have an honorary contract over with West Yorkshire ICB. So one of my priorities sitting within the ICB is focusing on integrated neighbourhood health. So the aim of the session this morning is to just take a bit of a deeper dive into where we are with integrated neighbourhood health as a system across West Yorkshire, and to try and identify some opportunities, so how we can use our evidence and our research here at the ARC, and next steps going forward, and how we can influence this transition into practice across our region. So we're joined this morning by my ICB colleagues. We've got Hayden Ridsdale, the Senior Strategy and Transformation Manager, and Paul Carter, Head of Research. So both have very kindly agreed to give a little presentation this morning. So we'll start there, and then we'll open up to have a bit of a discussion following those presentations. And then there's just a few call to actions and requests for myself at the end. So I'm going to hand over to my colleague Hayden, if that's okay. Just popped a few objectives up here, everything that I've just kind of discussed in relation to what I'm hoping you can all achieve and get out of the session today. And like I say, those objectives towards the end in relation to how we're linking ARC researchers in with the ICBs, and my call to actions. I'll discuss a few of them at the end of the session. So if I hand over to my colleague Hayden, and I'll let him introduce himself.
Okay. Can everybody hear me? Sorry, Sarah and I are in the same room together, and it's probably some kind of anecdote about how many NHS or ARC managers it takes to work a mute button, perhaps. I don't know, but thanks everybody for joining us and for having me. It's nice to be with you all, and I'm grateful for you guys sparing some time. So as Sarah said, I'm Hayden. I'm a Senior Strategy and Transformation Manager in the ICB, and I do a lot of work around neighbourhood health. What that means sort of in practice is that I do quite a lot of work around the kind of at scale enabling of neighbourhood health around sort of policy, strategy, some things around assurance, some things around learning, system partnerships, that sort of thing. But there are also within each of our 5 places in West Yorkshire sort of leads in those areas too. So it's a bit of a sort of twin track role that we run here in West Yorkshire. So I've put together a few slides that demonstrate really I guess what neighbourhood health is and the work that we're doing on this. I know some of you will know this already, but just sharing with you so we've all got that sort of same base level of understanding. And as Sarah said, I think we've got a really good opportunity with this conversation and Sarah's role to bring our worlds more closely together. I think we're really good at doing really good stuff, but I do think we could be better at being a little bit more robust with how we connect with research evidence and continue to build that into our processes. So what's neighbourhood health? I'm hoping this is not the first time you've heard neighbourhood health or INH or whatever sort of phraseology you want to use. So neighbourhood health is one of the top priorities nationally and locally. You will have seen that it's littered throughout the 10-year health plan that was published just a few months ago. You will know that it's fits into one of the Secretary of State's 3 big shifts around hospital to community. But more importantly, I think it's something that we've been doing for quite some time in West Yorkshire. And we've been doing that primarily for 2 reasons. One is that our system partners tell us that working in a more neighbourhood-based way, trying to support people where they live close to home in a more proactive way is the right thing to do. But also, and most importantly, people tell us that it's what they want from their care. So although neighbourhood health as a taxonomy is new, the ideas that sit behind it absolutely are not. And as it pops at the bottom there, although the language has changed ever so slightly, the focus is the same as it always has been. We do think that what the national policy brings is an opportunity for us to really accelerate the way in which we deliver on our neighbourhood health priorities, recognising that historically some of the progress that has been made has been despite the sort of enabling policy architecture rather than because of it as well. Can I just have the next slide, please, Sarah? Thank you. So here I've just summarised, and I'll not go through it all in tons of detail, what the 10-year health plan says about neighbourhood health. And if you don't know what the 10-year health plan is, but I'm sure you do, it's a sort of policy document that's published by the Department of Health and Social Care. And it was published following quite an extensive period of engagement through the Change NHS process. I think I'm right in saying it's the largest public engagement that there has been. So really extensive engagement that informed the government's priorities for over the next 10 years. And as you can see here, there's a number of things that are committed to that relate to neighbourhood health. So first and foremost, there's restoring GP access. And I guess what this really recognises is that you can't deliver a neighbourhood-based health service without having a strong foundation. And although the 10-year plan commitment is GP access in West Yorkshire, what we would recognise is that that's GP, pharmacy, optometry, and dental, as well as your sort of core primary care contracting groups, but also that to deliver a sort of full extent of the neighbourhood health model, you need to add to that the voluntary sector, you need to add to that services that are run through the local authority, and much broader. But absolutely recognise that restoring GP access is a key foundation. There's a commitment to develop 2 new neighbourhood contracts, so they are single and multi-neighbourhood provider contracts. The purpose of those is to enable, through contractual mechanisms, the delivery of neighbourhood health care. There's an indication nationally that they are being worked on at the minute in terms of the sort of draft forms that we expect them to take, but we're not too sure just yet when we would expect to see them, nor how long it would take for them to be the norm and operational in that sense. There's a real emphasis on multidisciplinary neighbourhood teams. We've published in West Yorkshire something called the Neighbourhood Blueprint, which focuses on this. So you may see multidisciplinary neighbourhood teams, you may see integrated neighbourhood teams, broadly the same thing. But it's important that what we're focusing on is breaking down the barriers to for those professionals to work together to deliver care in a more integrated way close to where people live. There's a commitment around neighbourhood health centres, which I'm sure you will not have missed. So the government's ambition here is that there will be one in every community. There's not a particularly robust timeline around that. There's also not a cost base for that, but there is a commitment within the 10-year plan that the Chancellor's upcoming fiscal statement will include some kind of business case around neighbourhood health centres. So we might expect to know a little bit more about that in the next 6 to 8 weeks or so. There's a real focus on the sort of practical rollout of neighbourhood health, and you may be aware that there's something called the National Neighbourhood Health Implementation Programme that's been launched nationally. I'm skipping ahead my slides in some way, but so 3 of our places in West Yorkshire are a part of that. And that's really unapologetic in the priority patient cohorts that it's focusing on. It focuses on, in the first instance, adults with multiple long-term conditions as the people that could benefit the most from integrated neighbourhood healthcare, but also as the priority, as the patient cohort that are driving a disproportionate share of hospital-based demand as well. So those priorities are set sort of for us nationally. And then the last point on there is something around an integrated health organisation. The idea of an NIHR may be new to some of you. You may have heard it in old style language too, but effectively what this is, it would be a sort of organisation that comes together to bring together acute care, community care, mental health care, perhaps primary care, social care, perhaps, a real mix. And what they would do is hold a whole population budget and be expected to be responsible for managing care right across the pathways. Again, it's not entirely clear the sort of timeline we're working towards. There is an intention to sort of trial this in some areas fairly soon, but there is key eligibility criteria, and that is that you must be a foundation trust to become an NIHR. Next slide, please. Sorry. Here I've just pulled something from the national policy guidance that we've received previously around neighbourhood health, and I'll sort of briefly articulate what it sets out. So there's 3 circles on the far left, on the left-hand side. Effectively, what they show is sort of ever broadening areas of focus for neighbourhood health. So that innermost circle is the area where we've been asked to start, and the expectation is that in the next sort of 1 to 3 years or so, we would be focusing on improving the way the NHS and social care work together to prevent people spending time in hospital, and then ever widening out to the sort of fullest extent of neighbourhood health, where you might start to talk about green spaces and access to leisure centres and that sort of more broad piece around determinants of health. I've probably covered most of the other stuff in here, so I'll move on to the next slide, please. And this point here, so you may have seen that this year there was some national neighbourhood health guidance published, I think in around February of this year. And that sets out the things that we are expected as a NHS organisation to focus on in the immediate term. So there's the 6 core components, which I've listed to the right-hand side. Worth saying that in West Yorkshire, in each of our 5 places, all of our places have programmes of work linked to those things as to how they're going to effectively improve the capability and expertise in this space to deliver neighbourhood health care. There's also an ask and clear commitment, which I think is really important, that we rigorously evaluate the work that we are doing as well. So I think that feels a really important point to labour, especially given the conversation today. Have the next slide, Sarah. Thank you. So I guess what I've thrown at you is a sort of whistle-stop tour of the national policy position and the national environment that we're working within, which, although we would sit here and say, and rightly so, that we've been doing this for quite some time, it does feel that the national frameworks are sort of catching up with that and starting to enable that a little bit better. What the next slide or two set out for you is how we're beginning to do this in West Yorkshire, and we'll hopefully give you some really practical things to hang on to where you think, oh, perhaps I could be more involved and engaged in that process. So at the pops at the top there, it's a really important point. We've got a heavily place-based system in West Yorkshire. So although I do work on neighbourhood health at a West Yorkshire level, the vast majority of that work and the detail of that work happens within those places. In the future, and you'll recall in the previous slide, I mentioned something called IHOs. The direction of travel is towards place-based provider collaboratives, and the expectation in our system has been that we would begin to mobilise them from the next financial year. So they will be the key sort of delivery driver of neighbourhood health. What we've said is that our immediate focus and immediate measure of success for our work on neighbourhood health will be shaped by 2 North Star metrics, both of which are on the screen. First of which is around the impacts that our neighbourhood health models have on reducing preventable unplanned care utilisation. I think the important thing to say here is that the system is under such pressure that that's likely to be a reduction in the growth rather than an outright reduction, at least in the sort of immediate term. The second and most really importantly is that we should increase prevention and early interventions. Now this feels a little bit harder to do, but clearly incredibly important, and there are lots of practical examples where our places are doing this that I can provide to you through a different medium. Can I have the next slide, Sarah? Thank you. So, and I guess sort of building on that, there are lots of things that we are doing in West Yorkshire. These are some of the sort of big things that we're doing that should enable all of the work from all strategic level. So I've already mentioned the neighbourhood blueprint that we published. I can, when I stop talking, pop a link to that in the chat if colleagues have not seen that. And what that does really is set the strategic direction expectations for neighbourhood health. There are, I believe, 5-year delivery plans in there for each of our places too. Worth saying that we need to treat that as a live document, given some of the significant changes the health system is going through. As I mentioned, programmes in place across those 6 places to deliver the 6 core components. 3 of the places that we've got are part of the NIHR. So those 3 places are Bradford, Leeds and Wakefield, and that gives them access to enhanced support from the national team, but also connects us nicely into the national policy development process. Doing work on developing place-based provider collaboratives, as I've mentioned, and through the NIHR board, which is the board that oversees a lot of the work that I do, we're progressing work around the strategic sort of components. So one of the key things there is how do we contract for and incentivise activity in a neighbourhood sort of model, recognising that the current contractual frameworks that we've got are perhaps not quite set in the way to do that. I don't think I've got another slide, have I?
No, everything.
So I will stop there. I'm conscious I've thrown lots of information at you, but I guess from my perspective, this is it's not a one and done conversation. This is a sort of basics really. Here's the work we're doing on neighbourhood health, and really keen to continue and to start connecting with you guys more.
Thanks very much, Hayden. Does anybody have any questions for Hayden just before we move on whilst we're here? I know we could spend way more than just 15 minutes speaking about such a complex issue. But I suppose if anybody's got any questions, you can either pop them in the chat as we go through, or feel free to pop a hand up now. If not, we will move on and ask our colleague Paul Carter to introduce himself, if he's still there.
I'm still there, yes.
Fabulous.
Some of you probably know me. My name is Paul Carter. I'm the head of research at the ICB, and you know me just because I've been around forever. And yes. So what I'm going to talk about is a piece of work we've done across sector organisations involving working with the voluntary sector, working with Leeds Beckett to try to improve an area of care that we're delivering across Bradford Place. The programme itself is called Rethink Pain. It's delivered by a voluntary sector organisation called Keighley Healthy Living, and it involves GPs identifying people that might be suitable for this community-based pain programme instead of the current pain pathway that we already had, and what happened to it and what happened to those patients, and trying to understand so that at the end of it we'd know whether this had been a success to us or not a success to us. So if we move on, first slide, I guess the first thing we all had to think about was, because we all came from different perspectives, different organisations, the thing we realised right at the start is we all spoke a very different language when we thought about how we interacted, how we came together, what these things might mean. And so we basically had to spend a bit of time engaging with each other and then engaging with our communities to figure out how this service would be delivered. The community pain service is more of a holistic service than it is a traditional clinical medical service. It relies on lots of work that's done out in the voluntary sector and out in the community to sustain the changes in people's lives away from that traditional clinical medical model. So, next slide, please. The first thing, obviously, we had to make sure is, were we asking the right questions? Did we have the right evidence for what we were about to do? And it did take us some time to figure out what we would realistically look at in order to try to understand the narrative of whether this was working in our community. We sort of looked at 4 key areas. One was about PROM that we could measure, that we knew Keighley Healthy Living had the ability to collect. One was about understanding what our patients thought of the service, understanding what the staff who worked at Keighley Healthy Living, and also some of the local GPs thought about this, and this was carried out by Leeds Beckett. And then there was understanding what was happening in the system to the patients as they transited from the traditional clinical model into this community pain service run by Keighley Healthy Living. So, next slide, please. So, we decided, or it was decided, that the Living Well with Pain scale would be used for all the patients that were referred into the service, and this would be collected out by Keighley Healthy Living as patients entered into the service, and then at the point where they were, I'm not going to say discharged because some of these people kept going, but after a 2 to 3 month period when they were into their program and when they were participating in lots of different activities that Keighley Healthy Living had designed in order to help with their pain management. We in the ICB then thought about this, and we were able to identify a SNOMED code that could be placed on every patient that was referred into the service, which meant that at any time later on, we'd be able to re-identify those patients so we could understand what had happened to them. The other thing you probably may or may not be aware of is obviously the ICB has a linked data model so that we can not only look at the GP record for a cohort of patients, we can also understand their A&E attendance, their inpatient, their outpatient, their use of 111, things like how many fit notes they get, all those sorts of things that we can see what is happening. And as I said, Leeds Beckett then took over in terms of running focus groups and interviews with some of the patients, some of the staff, and this has led to some publications for them as well around why the staff really enjoyed working in this environment, for instance. Next slide, please, Sarah. So what we looked at, and I guess the thing to think about is, because this is a real world, it's quite messy, so you can't do an RCT really. So all we focused on was what was happening to these patients, these people, before they entered the service, and then what happened to them after they'd been in the service, up to and including a year, which was our endpoint after they'd entered the service. So the thing that we found from particularly Healthy Living, who were able to collect this, is their mean score for their own self-assessed ability to manage their own pain had improved dramatically. It is a statistically significant change, and the fact that it was so low at the start shows you how difficult some of these people were living their lives, how hard it was, how they were just not able to manage. And there are some interesting case studies. Specifically, I think one that's always mentioned is about a man in his mid-60s who actually started attending local ballet classes because it helped with his stretching, and he became much more lithe and supple, and then joined a walking group, and then he went to art therapy, and all these things were happening. So people all felt, on average, that their ability to manage their pain had dramatically improved. Next slide, please, Sarah. And then through the SNOMED code, we were able to identify all these sorts of things. I want to say that because this was a place-based program, we couldn't really identify specific mass cohorts in other integrated neighbourhood team areas. So we took the approach that what we do is have a comparator that was the rest of the adult population in Bradford in the similar age range, and see what happened to both sets. So the population that had pain and went through the service, and then the rest of the adults in Bradford, and how they were typically using services in these 5 key areas. Next slide, please. To our surprise, we did find that there were significant savings in terms of money, but there were significant changes in terms of the number of GP appointments, the number of A&E attendances, the number of inpatient activity. And whilst outpatient activity stayed fairly similar, there was also a reduction in their use of mental health services. So in other words, by redirecting this cohort of patients, we saw this big shift in how they were using the system and the contribution that was making in terms of direct monetary savings. We took the approach that because we use living well with pain, you can't really map it to what's called NIHR, so we couldn't do the quality of life years, which we probably, in retrospect, might have done. But at the time, we had to get this up and running. For those of you who don't know, a lot of times when services, they have to be implemented very quickly. And so this is what we could do in the time we had available, all with the hope that at the end of it, we'd have better information about whether this was an appropriate use of our resource and whether this was a better way of getting our people to help manage their own pain out in the community. Next slide is just a take on Mark Johnson and Kate Thompson, who are the people from the Leeds Beckett and the paper that they published. And I think that's it for me right now. If you've got any questions, please do ask.
I think you've stunned everybody, Paul. Nobody's got any questions. If anybody does, please just pop your hand up or pop them in the chat. If not, we can move on.
I mean, there are some things I could say in terms of lessons learned.
Yeah, I think that would be really helpful.
People were interested. I guess there are several things to think about when you're working out with the voluntary sector and this sort of cross-sector thing. The first thing is, it is very important to establish that common language so that you all know what you're collecting, what you're measuring. The second thing I would say is it was important that we met and we established who was doing which bit and how it would all fit together and what were the key areas we were going to look at. The other thing, and on reflection, the thing we should have done is we only could identify one SNOMED code that wasn't currently in use anywhere else in Bradford that fit. Would have been better if we'd identified 3, because all we know at the moment is these are the people that we referred in. We'd be better off knowing the people that referred in, the people that then turned up with another SNOMED code, and then another SNOMED code that would tell us actually who finished the 13-week program before they went on. Because we must admit, all these results are great, but they probably dilute the impact on the actual individuals that did the full program. I guess the other thing as well to think about is, and the thing that we did find or lands really well, is the impact stories. Because if you don't collect those impact stories from those individuals to run alongside just the data, it sort of the data sometimes loses a bit of its translation in terms of the impact it's really having out there. And I guess my final thing would be is, obviously the service did get recommissioned based on the fact that we were able to come together, the ICB, Leeds Beckett, and the voluntary sector, to produce this sort of evaluation of what was happening in the service. So it's important to that collaborative aspect if you're going to work out in the community, because I think every bit of the system has its own little speciality that they can contribute.
Brilliant, thanks, Paul. And I think it's just been popped in the chat there. It's a really good example, like what's been said, of it, really tangible example of, you know, real life practice, what's happening down on the shop floor out in the real world. So that was brilliant, thank you. I think, speaking of collaboration, this is where my call to action comes in for all of our ARC colleagues. So I'm hoping that people will be able to assist us. So over at the ICB, myself and Hayden are kind of building a Integrated Neighbourhood Health webinar series. So essentially this is for any system partners who are interested or involved in the work. So they're for an hour, typically the last Wednesday of the month. They're online, like I say, just for the hour. And we've got different themes spread out over the course of 6 or 7 sessions, so 6 or 7 months, therefore. And again, the aim is per session to have a different theme. So population health, mental health, digital, palliative, end of life. And like I say, really thinking of that collaboration and being able to work together as a system, ultimately for one goal and for one result, would be really keen to get any of our ARC colleagues and researchers relevant to those themes to come and join those sessions. So after today, if anybody would like to contact me, or I'm happy to contact the theme leaders and managers relevant to the webinar themes, and get some kind of confirmations and dates in the diaries to see if people are willing to come. And I think it would be a really good opportunity to highlight any existing work that's taken place, or any past examples. Again, like Paul's done today, where we can link our strategy and our policies into, this is actually how we've implemented it, and these are the impacts that we've had in our region. Following on from that, another request. Again, with Integrated Neighbourhood Health, one of the projects I'm working on at the moment is just pulling together lots of case studies, evidence and research to present back to the ICB in the middle of October. So I suppose asking for any examples anybody has of work either that's ongoing, even if we've not got kind of final results and final impact evaluations, that they think would be a good opportunity to link back in, and to be demonstrated, like I say, in this kind of case study report back to the ICB. Does anybody have any questions on any of that? I appreciate I've covered quite a few. Hayden?
So it's not a question, Sarah,
Oh.
but it's maybe an offer here, I guess, as well. I'm reflecting back to a conversation I had with a colleague that some of you may know, Professor Peter Day. So in days gone by, I was also responsible for dental commissioning West Yorkshire, and I was working with Peter on something around supervised food washing, and Peter said to me at that point, the worst thing as a researcher is when your research sits on the shelf and it doesn't feel impactful. And I don't know all of your guys' specialty and interest and expertise, But what I do know is that, as I've mentioned, in each of our places, we are focusing on those North Star metrics. And to support our work on those North Star metrics, each of our places has developed what we call place priority cohorts. And effectively, what that means is they've looked at their data and they've tried to identify which cohorts of patients are driving the significant most chunk of disproportionate demand, basically. They're different across all of our places, but that might be a good thing. There's a real richness there. So, off the top of my head, there's some that have chosen frailty, there's some that have chosen palliative, there's some that have chosen children with a mental health need, there's some that have chosen people with multiple long-term conditions, a real range. I think it'd be a real strength of our system if we could ensure that where you have a specialty, you're able to connect in with that work. I think what we need to ensure is that as we're developing new models of neighbourhood-based care, we're doing it in such a way that is as evidence-informed as possible, recognising that our system hasn't worked in this way consistently and uniformly, as it perhaps operates in other countries or in the system like Staten Island system, for example. So if there are areas of interest that align with our North Star metrics, I think we could probably offer to connect you guys with those as well.
Brilliant, thanks, Aidan. Has anybody got any other thoughts, comments, reflections, questions? Yes, Andy.
Thanks, Sarah. Hi, Hayden. Hi, Paul. Good to see you both. I've got just a quick reflection, Hayden, and then I've got a few questions actually for you, I think, specifically, if that's okay. So the first thing, yeah, I mean, really enjoyed both your talks, actually. So big thanks for that. I know we've met before, Hayden, but just to kind of reorientate. So I currently lead a theme, the older people's theme in the current ARC. I'll be, well, hopefully once it's all signed off, officially co-director for ARC 2, which will be starting in April time, and also will be continuing in my role in terms of leading the Ageing Society theme. So the first thing to say, yeah, I think hugely keen to directly contribute to any work that's ongoing around certainly older people, multiple long-term conditions, because I know that there is a lot going on. Danielle Nimmons, who's one of our theme members, she's a clinical director of the SPEN primary care network. Danielle's hopefully going to be a good kind of route into those wider discussions, but really keen to link in. And I think it would be great across all the themes, actually, because there's so much relevant stuff going on. It would be so good if we can get those really strong links across all the themes. I mean, you mentioned child mental health, absolutely. But many of the other themes that I know have representation are doing so much work that's so relevant to everything that's going on that I think we're really important to do this. So any way that we can do this, we can pick it up separately, the mechanisms, but any way we can do this would be really, really good, because it's what we're all looking for, that impact, isn't it? So I think I had 3 specific questions, if that's okay. So the first one, could you just tell us from your perspective what the biggest challenges that you're currently facing around integrated neighbourhood health are? Because that's the way that we can then start to think about the sort of research questions. So your challenges can become our kind of research questions. So currently, in terms of integrated neighbourhood health, what are the biggest challenges that you and your colleagues are facing? That's the first question. I'll probably can I do them one at a time, if that's okay?
You can do them one at a time. That's absolutely fine. I mean, it'd be hard to give you a singular, and there are a couple that kind of immediately come to the forefront of my mind. One would be, I guess we're trying to engender a fundamental shift in the health system at a time when there is no more money, and we need to make a different use of the resources that we've got. So there's a bit of a question as to how on earth do you do that? Has that been done and successful anywhere else? I mean, my own research leads me to believe that there's often some kind of pump priming of resource, and we just don't have that flexibility. So there's a struggle there. There's another sort of linked struggle, I think, which is that we're talking about a quite a seismic shift in the way that the health service runs. It's quite hard to do that in a strategic sense. You often need to do that grounded in reality, grounded in the services that, for example, older people receive. So how do we do that very real service delivery in a different way and shift the system at the same time? It is a sort of difficult balance. And the other one, I'm not sure there'd be a research question in there, but just to be transparent, is that we're trying to deliver these neighbourhood health priorities when we all working in ICBs and NHS England, etc., are going through a period of incredibly significant change, headcount reductions and that sort of stuff as well.
Yeah. Okay. No, that's helpful. And I think Seb, so there's the kind of the economic angle that underpins so much of this, and we've got a very strong economics theme within the ARC alongside our data science theme as well as the kind of methodological stuff. So Seb might have some thoughts on that. I didn't see if Laura's joined or others from economics, but I think I spotted Seb. And then my second question was just how you're integrating the kind of different but linked policies. So there's integrated neighbourhood health, and the other things that, I mean, there's lots of things that are prominent in the 10-year plan, but specifically thinking around the modern service frameworks that have been developed. So cardiovascular health, mental health, which I think is a focus on severe mental illness, and in my world, frailty and dementia. And I'm feeding into the frailty and dementia kind of central national stuff, but it's just how you kind of integrating those and how you see they will develop over the coming 12 months or so.
Yeah, it's just a sort of multi-pronged answer here. There was one, and I'll say this, I know you were aware, Andy, we were going to be one of the systems that were part of the National Frailty Discovery Collaborative, and that will have a direct link into the drafting of that modern service framework. Unfortunately, we weren't able to proceed with that. But I guess on that very same point, I think we're a pretty well-connected system nationally in terms of our leadership, and now we're linked through to sort of national policy development processes. We're really keen to continue to do that. The other thing I would say is, so we're currently going through our planning processes for both the next year ahead, and then we've been asked to develop sort of mid-term plans, which are a duration of 5 years to around the end of the Parliament. And one of the things we're trying really hard to do in that process is to try and marry up some of the things that come out nationally that are usually about sort of service delivery standards, quality of care, things that are incredibly important, with the long-term shifts as well, to make sure that they're not mutually exclusive. And that's it can feel like quite a difficult thing to align an A&E target, for example, with a sort of longer term shift of resources for the community. But that's the sort of process we're trying to go through to align. I think it's fair to say we've not quite cracked that just yet. That's because we're about a month into the strategy development process as well. But I mean, I agree with the fundamental point. The position we can't arrive in is we can't have an integrated neighbourhood service that works incredibly well for a certain cohort of patients, and then alongside, let's say, a modern service framework for an acute hospital setting, alongside other things, there needs to be that coherence.
Yeah, thanks. That's really helpful. I've just seen Paul's made a comment as well. I'll have a read through that. I did have a third question, but I've forgotten it. So if I remember it, I'll come back to you. But Seb's put his hand up at a very good time, so I'll maybe go on mute.
Thanks. Yeah, given Andy's flag that I'm here, I thought I'd introduce myself. So I'm Seb Hind. I'm a health economist at the University of York. And yeah, I've worked for a long time with ARC and even the precursor, the Clark before it. And hopefully in ARC 2, as Andy says, when things get signed off, we'll be leading the early years, or the health economics component of the early years theme. The sort of thing that always sticks in my brain is, whenever we've tried to engage locally, and yeah, this goes back a long time, it's always been the challenge of the when and the sort of who, that we'll have had individual projects. So we did individual projects within the Vale of York on their weight loss services, and you get a really good engaged team and you're sort of working collaboratively. And then sort of the team at the CCG then was just essentially disappeared. It just, as far as we could tell people, disappear into the ether, and then all of the learning's kind of gone, and it's then very hard to find your way back into the system. And it is the eternal frustration that it feels like we were right at the point of setting up really good engagements, and then obviously the ICBs are now facing the latest challenge of staffing. So it's almost just good to know reflections while we're all here of like how we keep something together as these things change. Like, will it be through the knowledge mobilization fellows, or is there something we need to be doing more fundamentally differently about sort of regularly engaging across research and the ICBs? I'm not expecting a nice simple answer. It's just always been a frustration over the last years that trying to gain that impact is always difficult.
Yeah, it's a great question. There's a couple of things you make me think about when you sort of talk about health economics. One is so as you know, and you've just reflected, we're going through a period of significant change where the proposition is that our staff numbers would reduce by around half. The other thing that's sort of happening simultaneously that you may have seen is the publication of a document called the Model ICB Blueprint, and that sets out the functions that the ICB of the future will be expected to carry out. And in broad terms, it sets out that we should use data and evidence to understand population health needs and inform our commissioning intentions. We should set strategic commissioning intentions. We should contract for those through sort of purchasing and payer functions, and we should rigorously evaluate our endeavours in a sort of commissioning cycle style process. The things that it also sets out is the sorts of capabilities, capacities, and skills that you would need, and one of the big ones in that document is economics. And I don't know with absolute certainty, but I suspect there is a relatively small few handfuls of people in the ICB that have robust health economic skills. I think one of them might be on this call in the form of Paul Carter, to be honest with you, and I think he's one of very few. So we have got a real tension there, as you're saying, Seb, about sort of maintaining the sort of maintaining and growing the capacity at a time when the organisation's reducing. I think what it does, though, is it makes it even more important that we do hardwire the connections that you're describing that have been lost, because the reality is the organisation will at some stage reduce because we have to. And therefore, we need to ensure that we're connected in, perhaps through Sarah, in my case, to colleagues like yourself, to ensure that we are well connected. I think the other thing you've described for me really nicely is that we are really, and this is really important, right? To achieve real benefits for patients, we need to do some very real work on very real services. But we're really quite good at doing that in an isolated fashion. You described an example of that. But then when that project ends, the connectivity goes with it, and you're sort of left trying to navigate a system. So we have to be much more focused, I think, on hardwiring colleagues like yourselves into the system, so that it's not I'm leading a frailty project and Andy knows to come to me. It's that Andy knows where evaluation or where research sits in the, it sort of to be able to navigate that. So I think there's an opportunity for us here to build this into our organisational forms and functions rather than sort of more ad hoc connectivity through projects, really. So you're right, it's not an answer, but I think it's a violent agreement with your point.
Thanks, Nathan. That's really helpful. Well, it's sort of on the topic of health economics, we have a whole series of training systems that we've put in place that if there's ever a benefit from me or a colleague coming for half a day, even an hour, we've got all sorts of resources we can provide. It has always just been that identifying the way in and any appetite for it.
Thank you. Very kind of you.
Andy, do you have another question? Your hand's up.
Yeah, it was actually picking up Seb's point, actually. But just while it's in my head, Sarah, just in terms of if you're looking for case exemplars, we could kind of offer a fair bit to that, I think. I was just wondering, because Danielle, who I mentioned, Danielle's doing quite a lot of work in SPEN PCN at the moment around, frailty and dementia specifically. So we could probably bring something together in that area, but we can pick that up separately. My point was kind of picking up on what Seb says, in that's kind of a lot of the thinking behind the kind of response and impact groups that the themes are going to be establishing. So each of the 6 themes in the ARC round 2 we'll be establishing what we're calling a response and impact group, which is kind of bringing in the key people, regional and sometimes national policy and commissioning and practice, to help be those kind of bridges between the research teams and policy commissioning and practice. And that's exactly where I think now is a really good time to start mapping out exactly who those people are across the different themes, who can be those those connections that often works in, it's kind of bi-directional. It's often that people help pull the research outputs into policy practice and commissioning, but also, as I was trying to do then, also tell us what the key challenges that they're facing at the current time are, so that we can be responsive to need, rather than a research project that just sits outside of the current need and the current context. So that's what we'll all be doing in the themes over the coming months. But it can be helpful having direction from people like yourself and Paul, alongside Sarah and colleagues, just to know exactly who the right people are, because we find that difficult. It is tricky at times.
I'm just making sure Hayden doesn't have anything else to say.
I agree, but I think you articulated it better than I could respond to.
Fabulous, thank you. Paul, you've got your hand up.
Yeah, I think there's a couple of points to think about in terms of what Andy and Seb have just said. And that is, a lot of the research funding calls are very disease specific. And a lot of this work will not be disease specific. It'll more be generalistic, holistic care. So there may not be the right types of funding for research available, is what I want to put a cautionary note out there. The other thing is, and it's sort of the success we had in the last ARC and the success we've kept going on with the work we've done with Robbie Foy, for instance, where actually we've been able to design service improvement programs or transformational change where we've actually embedded the research activity within the transformational change from the start. So I think there's something about us being better at engaging with you to tell us this is the range of things that we're about to do. Is there anybody that could embed a research program within that? Or rather than just, as Andy put it, you coming to us and saying, we've got all these researchers that can do all this stuff. I think we're both going to have to talk to each other about this. That's it. I'm not saying anything else. You can move on to Andy because he's got his hand up.
Go on. Sorry, I was just going to come back on that, Paul. I think that's true historically. I do think, well, I mean, the NIHR is the research arm of the Department of Health and Social Care, so the NIHR funding should, and I think is more aligned with what the core priorities for DHSC are ultimately. And any application that goes in, you really have to sell the strategic alignment. So the work, how it aligns and complements the central policy, and everything's linked to the 10-year plan. So I think there are lots of opportunities actually. Sometimes, well, certainly the funding streams like HS&DR, health services and delivery research, that's what they do. It's looking often outside the kind of disease focus to the more complex health service change, health service evaluation, that sort of thing, and the big program grants as well. So that I think, yeah, true to some extent historically, I think there are lots of opportunities, and the ARCs are a good example. It's big infrastructure investment in applied research that aligns with national priorities. So I think we're in a decent place actually.
Paige, do you want to come in?
Yeah, it was just really what Paul was saying about identifying those opportunities to work together. I think that's kind of what we're trying to do in the ARC at the moment, is that when our researchers are starting a project or thinking of starting a project, we are encouraging them to, come to the knowledge mobilisation teams, and through you guys finding collaborators at the ICB right at the start, sort of to take on that journey. And I know that we've kind of almost cracked that little bit at the moment, that process, but we're sort of looking at it from the other side. So when Paul was saying, sort of from the ICB side, when you're starting a project and looking for research collaboration, then that's something that we could look at as like, it's almost like doing our process, but the other way around. But I think that as a knowledge mobilisation team, that can be sort of what we can look at from that side now. So just wanted to add in that. This sounds like a good idea.
No, it's a really good point, Kate, and I think it's highlighted that there's clearly some immediate actions that we can take forward, but like that, some further and wider discussions to be had outside of this space going forward as well. So anybody else got any final questions? Paul?
Yeah, it's one of the reflections I made, and it's the point at which you do get involved, because I think about the 2 months we had before we had to set all this up with reaping pain, getting these Beckett, working with the voluntary sector, identifying the right questions, identifying the right data that we could possibly collect. You wouldn't believe how valuable that is. But it was a very compressed 6-7 weeks of, we're going to have to get on and do this. And in a lot of times, or a lot of the time, that's the way we work in the ICB, that might be all the notice we get. So there's a good chance, just reflecting on what Andy said about HS, it might not align to those calls. So the ask might be, we need to do this upfront work on the grounds that there might be a research grant you can apply for 8-9 months from now when the program's up and running. But as long as we're collecting the right data that could support that, then it's still doable. We just tend to work on these very tight timescales that don't align to the research calls.
Andy, do you want to come in?
Yeah, just to pick that up, I think that's a really good point, Paul. And I think sometimes, again, historically, and I think it is changing again, been one of the difficulties, that tension between kind of research and policy and commissioning, kind of things come quickly in policy and commissioning. There's rapid change, and often people want, well, results in a usually quite a tight time horizon because of what they're being expected to deliver. And then sometimes, say, the evaluations are expected within a sometimes quite a tight time horizon. I think researchers have sometimes been a bit uncomfortable. We've found that difficult at times because we're sometimes used to working in the way that you've described. Although it's tight in terms of grant writing, it's quite a long process to get a grant funded. And often things have moved on even in that time period, if I'm honest. But I think things are changing. I think we're getting slightly more comfortable with working in that more responsive, well, we are more comfortable working in that more rapid, more responsive way. And I actually think from the policy and commissioning sides, things have moved, I think, in that people do look at the longer term horizon. People do see that actually it's the longer term horizon that we need. And things like the commitment in the 10-year plan, in the title, obviously, it's 10 years, isn't it? That's the obviously longer term time horizon, which fits more comfortably with sometimes with the timeframes for some of the, not 10 years, obviously, but that longer term time horizon, I think we can be more comfortable with. So I think things are kind of meeting in the middle from the two sides as well, actually.
Brilliant. Thanks, Andy. And thanks to everybody for your really valuable insights and input into conversation. I think it's been a really good space to have the very beginnings of some of these conversations and to be able to take them forward beyond the capacity of this call. So I'm just aware of time and aware that everybody's very busy. So I think if there's no immediate follow-up questions or thoughts, we'll leave it there for today. I'll just confirm with Paul and Hayden whether they're happy for their slides to be shared as well. But we obviously do have this session recorded, and we can send out some of the blueprints that have been discussed as well, just for ease of convenience, so that they're accessible. And then I will contact the team leads and managers in relation to that webinar series and that wider call for evidence and inclusion in that report. So if nobody else got anything else they'd like to add, we'll leave it there and hopefully see you all again soon.
Thanks, everyone.
Thanks, guys.
Thank you.
See you soon.
Bye.